what I focus on is a little bit of an accelerated recovery program, so that's what I'm going to talk about. So once you're at the end of the line, nothing else can be done for you, and we start talking about how do we put the new tread on your tire. Once you've got a flat tire, that's where I step in. So we'll talk a little bit about what works and what doesn't work, arthritis, joint replacements. I'll show you some success stories that we've had recently, and then at the end we'll focus on your questions. So if something comes up, something doesn't make sense, just stop me and we can talk about that. One of the things I think is the most important to keep in mind when I use the term, or I refer to arthritis, we're talking about osteoarthritis. And that's important because you need to understand that there's a big difference between osteoarthritis and rheumatoid arthritis and all these other rheumatologic conditions like psoriatic arthritis, or say if you have lupus or some of those things. Those all kind of get lumped down here in the rheumatologic causes for these problems. So when I use the word arthritis today, we're talking about run-of-the-mill osteoarthritis. Now, these two problems, these two conditions, they may have the same final common pathway. You may wind up getting your hip replaced or your knee replaced because of one of these issues, but there's a different reason why that has happened. So these rheumatologic conditions, these destroy joints because your body actually attacks your cartilage and destroys the joint. Osteoarthritis is for these different reasons, right? Whether it be if you have cam impingement in your hip or pincer impingement or a combination of the two and your labrum is destroyed and your hip wears out early on, you may wind up with osteoarthritis. That's different. So just keep that in mind. Osteoarthritis is what we're talking about today. And I really like this cartoon because people all the time will come in and, they've had this terrible pain or they want to know why this has happened to them and they want to know, why did this happen to me? And so osteoarthritis is really interesting because the more we learn about it, the more we realize we don't know. We're only really starting to understand all of these things in the sports world, for example, that lead to these worn out hips in young men. So there's definitely some genetic components. We're even learning more about the genetics of arthritis. Some people, I see them and they've got it all over their body. Why is that? There's genetic predisposition to some of these conditions. Trauma can lead to this. So if you've had a break in your knee, for example, tibial plateau fractures, the top of the tibia is the bottom of the knee joint. If you have a break into that can disrupt your cartilage. It's the same sort of process that disrupting your labrum can lead to an altered mechanics in your joint. It can happen to any of your joints. So if you've had a traumatic issue, you can wind up with post-traumatic arthritis. Infection creates a really hostile environment around the joint. So if you've had an infection in the joint, that can lead to destruction of your cartilage. Cartilage doesn't like a highly acidic, violent environment. So the same thing with inflammation. So I see people sometimes who've had repeated gout attacks. And so if that's not under control, that leads to repeated issues inside your joint, and that can destroy your cartilage as well. Metabolic issues, we're learning more about this also. For example, really poorly controlled diabetic patients. Those same sugar molecules that can go and lead to destruction of the vessels of your heart. You hear lots about diabetes and heart disease. Well, we're learning now that these metabolic issues can also predispose you to arthritic conditions. So we see a lot of that. And then if we're all lucky enough to live long enough, we're all going to wear the tread on the tire at some point. So these things have a finite lifespan too. So aging is also there. And I really like this picture on this side of the slide because this is exactly what everybody who comes in who has, say, for example, an arthritic knee, that knee usually looks a little bit bigger, and they want to know why that is. Well, as this process is going on inside your knee, then the capsule will start to thicken. It starts to react to everything that's happening underneath it. You'll start to see these cysts on the x-rays, and these are terms that just describe these changes that you'll see on the x-rays. The sclerosis underneath the bone is when the bone starts to look really dense on the x-ray because it's seeing extra stress. The cartilage inside there, just like when you were looking at those healthy hips, when Dr. Rayner has the camera in there and you see that cartilage, it looks nice and shiny and smooth. That's what healthy cartilage looks like. That's cartilage that you can try to preserve. When it starts to look like hay in the field, when it's wearing away and it's flowing when you look inside the camera, that's not cartilage that has a good long-term lifespan. So that's the fibrillated cartilage. The lining of the joint starts to react and it starts to get thicker. That pushes on the capsule, and this looks like a really boggy mess when you open up these knees when they've had a badly arthritic condition. And then you'll start to feel these little bumps that are around the knee or any other joint that's arthritic. And the reason this happens, we refer to these as osteophytes because bone only knows how to do one thing. It makes more bone. So when the cartilage cushion wears away, bone starts to press on the bone. The bone tries to decrease that pressure by increasing the surface area. So you start to get big bumps of bone that start to grow because it's trying to spread that pressure out over a larger surface area. And those are the extra bones that you'll see. And this is what it looks like, whether it be the hip or the knee. So this is a nice healthy looking knee. See all that space between there? That's where the cushion lives inside there on the end of your bone. Well, over here you can see where this bone is touching that bone. That's bone-to-bone arthritis. And this is what a nice normal hip looks like. Dr. Rayner can't help this one. It's already as good as it's going to get. But it looks like a nice round ping pong ball. And there's a nice cushion in there. But here's where these are extra bones that are growing down here. This is bone-to-bone arthritis in your hip. If he would have gotten to this one, he might have been able to straighten out this bump that's over here, which may have predisposed this hip to wearing out early. So that's what arthritis looks like in your hip or your knee. And I always like this picture because it sort of shows you the progression of what we're talking about here. So you might be over here where it starts to erode on the end of your knee. And then this is where you start to get into that fibrillated stage. It starts to flake off and it wears down and it gets worse. And then you can see where the bone will start wearing through and pressing on the other bone. And that's when you get to the end stage kind of arthritic changes there. And this is what is a post-traumatic example of arthritis. So this hip looks like a shark took a bite out of it. It's supposed to look like a round ball, but probably what happened is whatever led to this femur fracture may have driven that ball into that socket, and maybe it got depressed and maybe it was broken. And maybe that's what led to the destruction of that hip. But nevertheless, that's somebody that we'll show you an x-ray of that person later on. They ended up doing pretty well with a hip replacement. So I put this in here because there's so much overlap in our world. All of us see, just like was pointed out, sometimes people come in, they don't know what's going on. Sometimes they come in, we don't know what's going on. Sometimes I need his help, or I need Dr. Derman's help, or we all talk about taking care of people all the time together, because every one of these little joints has cartilage and nerve endings and nerve fibers, and there's so much overlap and so many things that can cloud your picture. And sometimes I don't know. Sometimes I need to ask them, sometimes they'll ask me, and sometimes we need to do the injections and things like that to try to figure out where the pain is coming from and how we can try to make you better. So there's a lot going on. It's complicated, and that's really kind of the genesis of how this all came about, trying to help each other figure these things out and help you figure out what's going on. So when it comes to arthritis, what can you do? What are the things that really work? Well, in my world, before we start talking about big surgeries, we try everything else first. So, whether it be soaking, I have patients who are made better with, different, kind of additives to bath and things like that. I tell people, absolutely, if it helps you, try it. Maybe it's ice packs, maybe it's hot packs. Exercise is good. A lot of times it's challenging exercise when you've got a really deformed, badly arthritic joint that doesn't move and you've got a mechanical issue, but weight loss is always good. And one thing that I tell people that is really a sort of a take-home message is that if you're carrying an extra few pounds and you've got a badly arthritic hip or knee, if the way the mechanics work, if you can lose 1 pound up top, that translates into about 5 to 6 pounds less on your hip or your knee with each step. So I've had people that are ready for an operation, they have a 5-pound weight loss, translates into about a 25, 30-pound difference on that hip or knee when they're walking around, and they decide they want to hold off on surgery. They can make that big of a difference. When it comes to medications, we use very liberally a lot of the over-the-counter things, and when it comes to injections, the things that really I've had a really good experience with are the steroid injections, like we've talked about. You can do those in your hips or your knees, and then these rooster comb injections. You've probably heard about these, the hyaluronic acid derivative medications. Those are also used very liberally. Admittedly, there's not a lot of overwhelming research that they do a whole lot, but what I tell people when it comes to these is that we have very few tools in the bag once the tread is worn off of the tire. So we try all these things before you wind up with an operation. And then if there's any joint preserving operations that we can do before you need your hip or your knee replaced or something like that, we talk to our sports colleagues about those. And you're always better off with your own parts is the take home. So we talk to everybody about this. Everybody who comes in, we, depending on where you are on this scale is where we start talking about the treatment options. So some people have bad arthritis, but they're not hurting that badly. Well, you may not be the right kind of person for a joint replacement. And some people have, pretty reasonable arthritis the way it looks on your imaging, but they're in really excruciating, debilitating, pain categories. And so these are people that we might talk to about a little bit more of an aggressive treatment, because we don't know why some people have terrible arthritis and no pain, and some people have minimal arthritis and excruciating pain. We don't know why that is, but you have to treat people, not just imaging. So before you start talking about a joint replacement, we try everything else first. Once we start down my road, we can't come back. That's the take-home message. And we make sure that we've tried all of these other conservative things. Some people are on the fence. Some people need to see joint preservation specialists before they consider it. Sometimes before I even sign somebody up for a joint replacement, I have them talk with Dr. Rayner just to make sure that we know that we're covering all of our bases. So that's very common. Sometimes you'll wear out only a portion of the joint. And so if you've worn out only one of your teeth and you go to see the dentist, they don't take out all of your teeth, right? So if you have a good looking set of teeth over here in the kneecap joint and the outside portion of the joint, and you've only worn down the inside portion of the joint, you might be a really good person for a partial knee replacement. And these are nice because you get to keep most of your knee, and people are happy with these because you get to keep those ligaments inside the knee. These ligaments are important because they talk to your brain. So this is a knee that feels more like your knee. People are happy with these. Now, if you're scared to look at the inside of a knee, turn away, because I've had some feedback before in this presentation where people don't like that. So just fair warning, okay? But this is a patient that, it's a lady that we took care of a little while ago. She has bone-to-bone arthritis on the inside portion. And then you can see over here how there's lots of space over there. She's got a healthy outside portion of the knee. And then I hope that you can see this okay with the lighting, but when we open this knee up, over here, this is the kneecap joint. You can see that it's nice and crisp. The cartilage is great in the kneecap, looks good. But this big stripe that's worn out of there, there's no cartilage on the inside portion. And then right there in the middle, you can see that that bone on bone is so irritated that it's even bleeding through there. That's that stripe of blood right there. So that's, you know, a knee that is so worn down and it's bothering, you know, you can imagine how badly it must be bothering her, that it's even bleeding through there. So this is somebody that we did a partial knee replacement for. She did unbelievably well. I continue to follow her along. I just did her hip replacement not too long ago, so she's really happy with that, and it's continued to work out really well. So who gets a total hip or a total knee? These are people, we've tried everything else. You've worn all of the knee joints. You can't be solved. Your problem can't be solved with just a partial knee. The medications are no longer providing you with relief. And the number one reason to do this is pain relief. The number two reason, pain relief. And then I'll let you guess what the number three reason is. Pain relief. So this is a lady that I took care of. She was a Wisconsin farmer. She had let this get to the point where she had been told by many people that this is too far gone. It can't be made better. She was, you know, you can see how far the bone on bone has worn there. It's worn away the tibia. She had a huge hole in her bone. It was worn so badly. So this is a pretty extreme example, but even when the leg is this crooked and this badly deformed, we can still get you straightened out and get you back on track. So this is a little bit more of a robust reconstruction because she had such a degree of deformity. It needed a little extra support, but she's continued to do really, really quite well. And that other knee's bad too, but she just toughs it out. The lady's really remarkable. So one of the things that I do and has been a tremendous success for us is kind of implementing our accelerated recovery program. And so we'll talk a little bit more about this, but what you're seeing here is a demonstration of the support that we have and that is required to make this happen. So to get you through one of these big operations safely and efficiently and have you back in action in no time, it really takes a village. And so thank you to all of our team, because that's really, what we do. The surgery side of it is important, but it's a small part of it, and it's a big picture process. And so this is what we're constantly refining. We have a team of people that work with us on every aspect of everything that goes on, from even before you have an operation up until, through your operation, a lot of education beforehand. We work really closely with our anesthesiologists. We have a program that's designed to really avoid heavy-duty narcotic pain medications. We use our minimally invasive techniques, and we'll talk a little bit more about that a little bit later on. We have a team approach with tremendous support, as evidenced by everybody who's here supporting us. And that's how we get people through these things, and even sometimes in the same day we'll have you home after a major operation. So this is what the pain management regimen and where the ideas surrounding this kind of multimodal approach, this is where this comes from. So you have an operation, you have to have tissue injury, you have to have an incision to have an operation. That leads to inflammation, that stimulates your nerves, your peripheral nerves pick that up, carry it to your spinal cord, and it goes to your brain. So everywhere these pain pathways become additive. So we look at that as a chance to do something in every one of those avenues. Now this is your old-fashioned, this is the way your grandmother had her hip replaced. She put a huge incision on somebody, nobody was really paying attention to all of these issues. They stimulated pain at every one of these avenues, and then you would come out of the operation, you'd wake up, you'd be in excruciating pain, they'd give you a pain pump. You'd hit your button, boom, 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 you'd pass out. Okay, you felt better for a minute, you'd wake up in excruciating pain. Boom, 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 pain, pain, pain button. And you'd wind up with all kinds of problems surrounding IV medicines, constipation, nausea, vomiting, all of these issues that become big-time problems. So now we've started to really think about not just the operations, but how do we get people through these things faster, easier, and use all of these other tools that we have to help minimize this pain. I'm not going to lie to you and tell you that it's a pain-free process, but I can't even remember the last time I used one of these pain pumps. And people are not coming out of the operating room, trying to put a gun to their head. They're really quite comfortable, really very quickly, and we oftentimes have people home the day of surgery after one of these big operations. So who's appropriate for this kind of thing? Well, you've got to be motivated. You've got to be, have the appropriate kind of, support for this. So it's not like we do a big operation on you and cut you loose if you don't have the right kind of situation to support that. So it's important. And you've also got to have the appropriate set of medical comorbidities to make it safe for you to be home right after an operation. So this is that person we looked at with the shark bite out of their hip. And so that's what a hip replacement looks like. This person did really quite well with that, really very quickly. And so this is just some of our patients that have had these operations, and we check on people usually at about the 10-day to 2-week mark after the operation. So this is one of our hip replacement patients, about 2 weeks from surgery.
About 2 weeks after surgery.
Excellent. How's your hip feeling now?
Awesome.
So 2 weeks from surgery, this is another patient that we'd operated on. We'd replaced her hip. She's a younger lady, had a terribly arthritic hip.
Looking pretty perfect. Hey, show me a little dance too. How about that?
So this is our new joke now. So some dancers are better than others, but after hips now at the 2-week mark, we catch everybody dancing in the hallway. So people are home quickly. Really very pleased. So I put this in here just to make a quick comment about this. So we'll talk a little bit more about anterior hips here in a minute, but it's not as though if you have a posterior hip that's a problem. So anterior hip is my best operation and kind of what I specialize in, but we still do this. This still works well. And if you have any questions about this, as far as approaches, we can talk about that also. So this is, I've found very interesting for people and always well received. So what we do, what I specialize in is this minimally invasive muscle sparing hip replacement approach. And what you're looking at here is this is the hip joint. The head is up here, the feet are down here, and this is how you do a hip replacement through the front of the hip without detaching any muscles. You put the hip in between the muscles. So you move these muscles out of the way. We have these specialized retractors, and this is how you get down to the hip joint. We'll show you some of this anatomy also from this view that Dr. Rayner specializes in making better. So we open up this hip joint. This is the capsule of the hip joint, which is a big part of his operations too. Management of this can be really tricky and challenging, which is why I don't do his operations. So this is what the ball of the hip looks like. Right up along here, right around the top up there, that's where that labrum lives. So that's that gasket that keeps your hip inside the socket, right there. So we move these muscles out of the way. He spends many hours trying to fix that labrum and salvage it. I can take it out of there in a couple minutes. This is a step in the operation that I actually don't practice in my operation, but this is the best video that I could find. So this is what that badly arthritic ball will look like when it's taken out of the hip joint. This just shows you some of the soft tissue releases that are necessary to do this operation. So then they'll put this hip back in, and then they'll cut this ball and this neck portion out of there because that tire is flat and worn off. There's no tread on it. So once that comes out of there, then we have to reshape the socket. And so the socket is also badly worn and oftentimes deformed and no longer the same shape as what you're going to put back in there. So we reshape that socket with a little cheese grater. So you'll see that come into the field here in a moment. Once your cheese grater goes in and reshapes your socket, then you're ready for your titanium shell, which will rest inside the bone. That'll hold your new liner surface. So like we talked about earlier, we no longer use these metal liners. This is a space-age plastic liner. And then we have this special equipment, fancy tables. That's what this extension is that comes in here so that we can access the top of the femur to then get the appropriate size stem that will hold your new ball that will then rest on the new bearing surface on the new socket. So once it shows you the stem portion, I'll skip past the rest of this video because it's sort of redundant after that. So these stems then go down inside, and that's what will hold the new ball. And this is just showing you what a trial component would look like, because we always make sure it's going to work okay before we decide on the final pieces and the sizing and the length of the leg and all of those kind of things. So we can talk more about that later. So then this special table attachment will then help us bring the leg back down to where it needs to be, then put the hip back into place, let the muscles snap back over top, and that's how you get the hip in without taking any muscle off.